On March 23, 2010, President Obama signed a comprehensive health care reform bill. He signed it into law and is known as H.R. Bill 3590. On March 25, 2010, Congress passed the Reconciliation Act, which is called H.R. Bill 4872. This bill modifies the bill signed by President Obama. What are the highlights of this new law, and how can this law be good for you or your loved ones? Before you answer that question, ask yourself, am I or my loved one prepared for a catastrophic and disabling event such as a heart attack, a stroke, a serious accident, cancer, or even Alzheimer's disease? If not, then planning for such a contingency is not only smart, but also necessary. Remember, tomorrow is not promised to you. No one has a crystal ball that can accurately predict your future. Therefore, life is not waiting for the storm to pass, but rather it's learning to dance in the rain. By planning, you are learning to dance in the rain. Hello, my name is Attorney Ramsey Barawi, and welcome to Your Money, Your Life. In this segment, I will attempt to give a summary of the two bills, H.R. 3590 and H.R. 4872, which together comprise the healthcare reform package. I will also attempt to highlight the significant provisions of this legislation that impact older adults and people with special needs. Let me start by saying that this law is complicated, very long, and appears expensive. As regards the cost of this plan, it has been reported that the healthcare reform plan will cost $940 billion over 10 years. Over that same time span, the Congressional Budget Office estimates that this plan could reduce the deficit by $143 billion. The plan is intended to increase coverage to 32 million Americans who are currently uninsured. The uninsured and self-employed would be able to purchase insurance through state-based exchanges with subsidies available to individuals and families with income between 133% and 400% of the poverty level. Beginning in the year 2014, separate exchanges would be created for small businesses to purchase coverage as well. Also, individuals and families who make between 100% and 400% of the federal poverty level and want to purchase their own health insurance on an exchange are also eligible for subsidies. However, they cannot be eligible for Medicare, Medicaid, and cannot be covered by their employer. Eligible persons receive premium credits with a cap on the amount of their premium contributions calculated on a sliding scale. How will we as taxpayers pay for this healthcare reform? In that regard, the law provides us with some guidance. Starting in 2010, there will be a Medicare payroll tax on investment income. The Medicare payroll tax will be expanded to include unearned income such as interest, dividends, and rent. That will represent a 3.8% tax on the investment income for families making more than $250,000 per year or individuals earning $200,000 a year. Beginning in 2018, insurance companies will pay a 40% excise tax on so-called Cadillac or high-end insurance plans worth over $27,500 for families or $10,200 for individuals. Dental and vision plans are exempt and will not be counted in the total cost of a family's plan. Also, a 10% excise tax on indoor tanning services will be imposed to help pay for this health care reform. Other particulars of the legislation are the creation of mandates. For instance, in 2014, everyone in the United States must purchase health insurance or face a $695 annual fine. There are some exceptions for low-income people. Why this mandate? Because if you require insurance companies to take on all persons, including those with pre-existing conditions, then people will stay uninsured until they get sick or need an expensive operation. At that point, they will buy insurance, get taken care of, and drop back out. This is an obvious recipe for driving insurance companies out of business. So to make this work, the law needs a mandate to make sure everyone's insured all of the time, not just when they get sick. And if you have a mandate, then the law needs subsidies for poor families so they can afford to obey the law. And if you have subsidies, then you need some kind of funding mechanism. Another mandate deals with illegal aliens. Under the healthcare reform law, illegal immigrants are not eligible for Medicaid. As regards abortion, the bill segregates private insurance premium funds from taxpayer funds. Individuals would have to pay for abortion coverage by making two separate payments. Private funds would have to be kept in a separate account from federal and taxpayer funds. No health care plan would be required to offer abortion coverage. States could pass legislation choosing to opt out of offering abortion coverage through the exchange. Speaking of exchanges, illegal immigrants will not be allowed to buy health insurance in the exchanges. And they won't be allowed to do so even if they pay completely with their own money. Now let's look at Medicare. But first, let's talk about what is Medicare. Medicare is health insurance for people who are age 65 or older, or who are under age 65 with certain types of disabilities, or people of any age with end-stage renal disease. There are 4 parts to Medicare, which include Part A, Part B, Part C, and Part D. As regards Medicare Part D, or the prescription drug plan, the healthcare reform package gradually eliminates the Medicare Part D coverage gap, also called the donut hole. It intends to do so by the year 2020. Beginning in the year 2011, pharmaceutical manufacturers are required to provide a 50% discount for brand-name drugs filled in the Medicare Part D coverage gap. Beginning in the year 2013, a federal subsidy for brand-name drugs will be phased in through 2020. The law also has a provision for generic drugs. Beginning in 2011, a federal subsidy for generic drugs filled in the Medicare coverage gap, or donut hole, will be phased in through 2020. The subsidy can be as much as 75%. The healthcare reform package provides a $250 rebate to Medicare beneficiaries who reach the Part D coverage gap in 2010. This is effective January 1st, 2010. It also provides Medicare coverage with no copayment or deductible of an annual wellness visit and creation of a personalized prevention assessment and plan. Prevention services include referrals to education and preventive counseling or community-based interventions to address certain risk factors. In other words, this law encourages prevention. The healthcare reform law eliminates Part D cost sharing for full benefit dual eligible beneficiaries receiving home and community-based services. Dual eligibles are individuals who are in receipt of medical coverage from both Medicare and Medicaid. It also restructures payments to Medicare Advantage plans. Medicare Advantage plan is a drug plan offered through a private insurer such as an HMO, which offers Medicare prescription drug coverage. Moreover, the healthcare reform statute requires the Secretary of Health and Human Services to suspend Medicare Advantage plan enrollment for 3 years if the medical loss ratio is less than 85% for 2 consecutive years, and to terminate the plan contract if the medical loss ratio is less than 85% for 5 consecutive years. This provision is effective beginning in 2011. What is meant by medical loss ratio? Simply put, it is the percentage of health insurance premiums that insurers use to provide health care to their customers. For example, if an insurer uses 75 cents out of every premium dollar to pay its customers' medical claims, the company has a medical loss ratio of 75%. A medical loss ratio of 75% indicates that the insurer is using the remaining 25 cents of each premium dollar to pay expenses that do not directly benefit policyholders, such as salaries, administrative costs, advertising expenses, agent commissions, and profits. Following this example, under the Healthcare Reform Bill, 85 cents of every dollar must be used to pay for medical claims. In addition, the Healthcare Reform Bill establishes an independent payment advisory board, which will have authority to make recommendations for Medicare cost savings. The recommendations will take effect if Congress does not enact an alternative proposal that achieves the same cost savings. It is important to note that this board cannot make any recommendations that will impact premiums or benefits. Also, the board cannot make any recommendations for cuts in a year when national health expenditures grow at a higher rate than Medicare costs. In addition, it establishes a Medicare shared savings program that promotes accountability for a patient population and coordinates services under Medicare Parts A and B, and will encourage investment in infrastructure and redesigned care processes for high quality and efficient service delivery. It will allow groups of providers who voluntarily meet certain criteria to work together to manage and coordinate care for Medicare fee-for-service beneficiaries through the accountable care organizations under Medicare. The goal of the accountable care organization is to encourage physicians and hospitals to integrate care by holding them jointly responsible for boosting Medicare quality and controlling Medicare costs. Under the healthcare reform law, accountable care organizations that meet quality performance standards are eligible to receive payments for shared savings. Under healthcare reform, Medicare Part B and D premiums will be tied to income. Accordingly, more Part B and Part D beneficiaries will be moved into higher income categories, meaning higher premiums. The proponents of health care reform believe that this reform will strengthen Medicare and extend by 9 years the life of the Medicare Trust Fund, which, without some intervention, was projected to be depleted in the year 2017. Insurance market reforms are also addressed by the health care reform law. For example, effective 6 months after enactment, insurance companies can no longer deny children coverage based on a pre-existing medical condition. Starting in 2014, insurance companies cannot deny coverage to anyone with pre-existing conditions. These provisions are similar to the Massachusetts law. Excuse me. Also effective 6 months after enactment, individual and group plans will be required to extend dependent coverage to adult children up to age 26. In addition, rescission of coverage is prohibited and waiting periods for coverage greater than 90 days are eliminated. Let's look at the impact of the healthcare reform package on Medicaid. First, by way of explanation, Medicaid is a public health insurance program for people who can't afford to pay for medical care. In Massachusetts, Medicaid is called Mass Health and has financial qualification requirements. The qualification requirements require meeting stringent asset and income guidelines. The healthcare reform bill modifies the spousal impoverishment statute to mandate that states include the spousal impoverishment protections to their waiver programs. What is meant by waiver programs? A brief explanation is in order. At one point in time, Medicaid dollars only paid for institutional services. Today, however, Medicaid allows more diverse services and supports for individuals in the community by waiving the need to get those services in an institution, hence the term waiver. In addition, the healthcare reform law establishes the Community First Choice option, a state plan option to provide community-based attendant supports and services to individuals with disabilities who are Medicaid eligible and who require an institutional level of care. States that choose the Community First Choice option will be eligible for an enhanced federal match rate of an additional 6 percentage points for program expenses. This provision, effective October 1, 2011, will sunset after 5 years or on September 30, 2016. Also, the healthcare reform bill creates the State Balancing Incentive Program. This program will run from October 1, 2011 to September 30, 2015. It is intended to provide enhanced federal Medicaid matching to states that currently spend less than 50% of total expenditures for long-term care on services in the home or community to increase their proportion of non-institutionally based long-term care services. The healthcare reform bill expands Medicaid to cover individuals under the age of 64 with incomes up to 133% of the federal poverty line. As regards long-term care, the healthcare reform bill establishes the Community Living Assistance Services and Supports Program, or what is known as CLASS, a new national long-term care insurance program funded through voluntary payroll deductions, which will provide a cash benefit to individuals who are unable to perform activities of daily living and thereby allow them to purchase long-term care services and supports. In addition, this law allocates $10 million per year, $10 million that is per year, for 5 years to continue the Aging and Disability Resource Center initiatives. The Aging and Disability Resource Center is an initiative launched in 2003 by the Administration on Aging and the Centers for Medicare and Medicaid Services. This initiative is part of a nationwide effort to restructure services and supports for older adults and younger persons with disabilities, and it complements other long-term care system change activities designed to enhance access to community living. This initiative is designed to address many of the frustrations consumers and their families experience when trying to access needed information, services, and supports. In other words, it strives to reduce consumer confusion and build consumer trust and respect by enhancing individual choice and informed decision-making. This strategy can also help break down barriers to community-based living by giving consumers information about the complete spectrum of long-term care options. Care coordination is another topic addressed by the healthcare reform law. It creates the Independence at Home demonstration program to provide high-need Medicare beneficiaries with primary care services in their homes and allow participating teams of health professionals to share in any savings if they reduce preventable hospitalizations, prevent hospital readmissions, improve health outcomes, improve the efficiency of care, reduce the cost of healthcare services, and achieve patient satisfaction. This new law also creates an innovation center at the Centers for Medicare and Medicaid Services to test, evaluate, and expand different Medicare and Medicaid payment structures to foster patient-centered care and care coordination across treatment settings. Also, the healthcare reform law establishes a national Medicare pilot program to develop and evaluate paying a bundled payment for an episode of care that begins 3 days prior to a hospitalization and lasts until 30 days following discharge. It also creates a new Medicaid state option under which Medicaid enrollees with chronic conditions, including a mental health condition, substance abuse disorder, asthma, diabetes, heart disease, or weight problem, can designate a provider or a team of health care professionals. As regards end-of-life issues, the healthcare reform law does not make any such provision. As regards nursing homes, the healthcare reform law encourages transparency. It requires nursing homes to disclose their owners, operators, suppliers, financiers, and others with whom they do business so they can be held accountable for the care residents receive. It also requires the government to implement a system to collect and report information about how well nursing homes are staffed, including accurate information about the hours of nursing care residents receive, staff turnover rates, and how much facilities spend on wages and benefits. In addition, it requires cost reports that nursing homes will file with the government to show expenditures by category, such as nursing, therapy, capital assets, and administrative services. As regards civil monetary penalties or fines, it requires that fines be paid and be held in escrow pending appeals rather than allowing nursing homes to delay payment indefinitely while they file appeals. Lastly, it provides training to nursing home workers who care for residents with dementia to prevent abuse. Speaking of elder abuse, the healthcare reform bill includes an Elder Justice Act, which establishes an Elder Justice Coordinating Council to make recommendations to the Secretary of Health and Human Services on the coordination of activities of federal, state, local, and private agencies and entities relating to elder abuse, neglect, and exploitation. It also provides $400 million in first-time dedicated funding for adult protective services, as well as $100 million for state demonstration grants to test a variety of methods to detect and prevent elder abuse. In addition, it provides $26 million for the establishment and support of elder abuse, neglect, and exploitation forensic centers to develop forensic expertise and provide services relating to elder abuse, neglect, and exploitation. All this means that for the first time ever, efforts to prevent elder abuse will be coordinated at the federal level. Additional research, worker training for adult protective services, and elder abuse forensic studies, plus an ombudsman to oversee the program will provide crucial help for a problem that, according to experts, is only expected to grow as boomers reach retirement age. In my view, this comprehensive federal legislation is well overdue. The healthcare reform law requires criminal background checks. It extends to all states an existing pilot program that enables states to conduct national criminal background checks, including fingerprint checks, on individuals who apply for direct patient access jobs in long-term care facilities with home care agencies that receive funding from Medicare or Medicaid. As regards workforce training, the healthcare reform law provides funding to support training in geriatrics, chronic care management, and long-term care. It also establishes federal traineeships for individuals who are preparing for advanced education degrees in geriatric nursing, long-term care, and geropsychiatric nursing. In addition, it provides grants to foster greater interest among health professionals such as nurses, clinical social workers, pharmacists, and students of psychology to enter the field of geriatrics, long-term care, and chronic care management. Moreover, it establishes a national panel of long-term care workforce experts to develop the core competencies for these training programs and to make recommendations on how such training could be provided. It is obvious that this healthcare reform law promises many things over a 10-year period. It promises to extend coverage to millions more Americans. It promises over time to remove the exclusion for pre-existing medical conditions and promises to fight elder abuse. It puts an end to rescissions. In other words, insurance companies can no longer cut someone when he or she gets sick. It also requires that everyone purchase insurance. The health reform law excludes illegal immigrants from qualification. Abortion is not covered. New screening procedures will be implemented to help eliminate health insurance fraud and waste. A temporary program is established for companies that provide early retiree health benefits for those between the ages of 55 and 64 in order to help reduce the often expensive cost of that coverage. The law provides a 2-year temporary credit to encourage investment in new therapies for the prevention and treatment of disease. Will this legislation deliver on all these promises? Only time will tell. One thing that this law does not address is tort reform. What is tort reform? Generally speaking, I'm aware of 3 types of so-called tort reform. The first limits circumstances under which an injured person can bring and file a lawsuit. The second limits access to jury trials. And the third limits or places caps on the amount of money an injured person can be awarded. It is unclear whether these types of tort reform would result in health care savings. It is more likely that these strategies would simply shift the balance of the scales of justice. The primary and key issue in healthcare reform is to get skyrocketing medical costs under control while at the same time covering the uninsured. Having said that, I fervently hope that our tax dollars actually go toward paying for medical care and protective programs and not to funding an unwieldy bureaucracy. We can all debate the best way to lower healthcare costs. However, making sure that the dollars we do spend on healthcare actually get spent on taking care of the ill and keeping everyone else healthy and safe is a good place to start. In conclusion, the world is a complicated place. This is a complicated law. While the magnitude of change may seem too narrow for some and too overreaching for others, the healthcare system in this country will definitely be altered once the details of this reform law are implemented. Is there any nobler government endeavor than to guarantee that every man, woman, and child, irrespective of age, race, color, or socioeconomic status, is assured equal access to good quality, affordable medical care? Will the healthcare reform law deliver on the promise of controlling medical costs, providing a more inclusive healthcare system, getting private insurance companies under control, and providing the American people with quality medical care at affordable and reasonable prices? Are we witnessing the beginning of another period of significant social change? If so, this change will come gradually. In my lifetime, our society has made slow, incremental, and significant economic and social improvements that built our large middle class and at the same time diminished in our pluralistic society the stigma of minority and disability status. Did this happen overnight? No, it happened over time as people's attitudes, values, and perspectives changed. Therefore, only time will tell whether the healthcare reform package will represent the next important step in the direction of social change. This is our show. As always, thank you to you, our viewers, for watching Your Money, Your Life. My name is Ramsey Barawi.